is now moving down, especially with high energy sources and suction and so on. So our next speaker, please welcome the President-elect, Professor Joe Philip, who is going to talk about single-use scopes and smaller scopes. Thank you, Joe, for joining.
Thank you, Bhaskar, for the invite, and thank you all for joining on this evening to listen to miniaturization and minimization. Let me share my slides. So for those of you who don't know me, I'm a urologist in Bristol, and also, as Bhaskar said, the President-elect. The remit of my talk is about small ureteroscopes and whether that's the future of endourology. So pertaining to this talk, I have no disclosures. I would like to bring to the attention of all the attendees about the factors that influence treatment choice. One has to be careful and cognizant about the availability of shock wheel lithotripsy and PCNLs. It's about size, the site, the anatomy, the obstruction possibilities, and I come to that as we go along. And obviously, the resources available locally and also one's own success rates. And often, as now we are getting more used to it, patient preference. But they would like to have a single procedure with a smaller scope, with the likelihood of not having a stent rather than multiple procedures. So this is our acute stone service pathway, which was submitted as a case report by the GURFT in 2023. And as you can see, a significant number of patients have ureteroscopic surgery because either they have stones that are not visible on x-rays for other treatments or would like to have a single one-shot treatment. Now, over time, from 1964, when the proper first endoscope for the urinary tract was identified, we've reached a stage where with endoscopes that there are now flexible ureteroscopes with 7.5 French and potential to have even smaller. But the benefit of all these is that one can go into most ureters with the lower two-stage rates and a reasonably good working channel for good flow and introduction of instruments. But what are the disadvantages and advantages of these single-use scopes? In patients with multi-drug resistance, as some places in the world see, there is a reduced risk of contamination. There's the potential for teaching novices, so you're not risking a 10,000-pound scope by enabling educating and training your fellows, as you'll see in my next video. There is also a potential to use the flexible ureteroscopes in more challenging settings with the possibility of breakage, like in acute angles in the lower calyx, where the stone may be anteriorly in a calyceal diverticulum, where one has to do a secondary deflection to get to visualize the stone. I mean, the disadvantages are that in this modern stage of sustainability and disposable issues, the single-use scopes are becoming a major challenge on how we can minimize plastic degradation. Maybe the way forward would be a hybrid approach, especially focusing on challenging cases, patients with large stone burden, training cases, low pole stones, and also in those with tight ureteral access, like patients who've had radiotherapy in the past. So this is a video, as you can see. This is the flexible ureteroscope in a BMI 40 patient. As you can see, the anesthetist is struggling to keep the tidal volume low. My fellow is using the scope, used to a reverse standard deflection. We use a standard deflection that is down, up is up. And the whole idea is to laser fragment using reasonably high power this large lower pole and extruding into the renal pelvis partial stagon. It is in the anterior calyx, which is narrow infundibulum with the tip of the stone burden that you can see which is being laser fragmented, and you can see the suction scope then enables visualization with suction of the fragments. This is indeed beautiful, reduces the risk of leaving any large burden stone. Most of it are fragments that can be washed out, even in patients where the tidal volume is so high, the kidney is moving about. And all credit to the anesthetist who is trying her level best to keep the kidney still for us. And this is a wonderful case where you can use the suction to enable better visualization. And this is even more so in patients who have significant matrix. In the olden days, before the use of the suction scopes, one could only flush out the matrix and hope that they would wash out. Now you can literally suck out the matrix, use a collecting the gynecologists use for the sucking out the products of conception, and you can get the matrix for analysis. So these are some of the salient benefits of this suction scope. There is less ureteral access failure, like in the paper published recently by Ali Telishinsky, there is only a 0.9% failure rate with the 7.4 French access sheet. The benefit of this is also one can use smaller caliber ureteral access sheets. So I have now come to just using 10 to 12 access sheets. So the need for dilatation of the ureter, the risk of damage to the ureter is quite low. And I may go a bit more challenging as we move into ureteroscopies in patients who have had multiple CT scans, pregnant patients. One could even consider radiation-free procedures. And more importantly, also think about one's own ergonomics. The recent workforce paper by Steve Payne and Ian Pierce have quoted our working lifespan as a consultant with median 29 years. So to be carrying heavy ureteroscopes for that long is not feasible for any human being. So these are so much more lighter, and the wear and tear on your thenar eminence, especially if you use the reverse deflection scopes, is quite challenging and limits our working life. The limitation is the working channel flow. So if you use smaller and smaller scopes, then the worry is that the channel will be less, especially if you have an instrument. So one needs to also have smaller instruments. And in the development of these ureteroscopes, one should also look at the tip design and how much torque can be enabled in the distal end of the scope so that one can reach small areas, calyceal diverticular, anterior calyces, especially in the lower pole that where the stone is, and often a challenge for PCNLs. But it's not just about stones. And as you can see here, this is a patient who's had a cystouretrectomy, ileal conduit, nephrouretrectomy, and this is the single kidney patient. Decided patient will not want to go on dialysis, and this is a palliative tumor ablation. And as you can see, this is an interval recording which has been split. The initial part was lasering, and then there is the suction of the debris, suction of the clots, so that one can visualize the area better. There is some interference with high-powered lasering, and as you can see, a careful suction of the debris helps one visualize the tumor base. All this in subsequent videos, subsequent imaging had shown that it had all sloughed off. Now, 18 months later, he's still ongoing with a 3-monthly laser ablation as and when required, beating a palliative approach, which would have been a median lifespan of about 9 months. So these are the benefits, as I can see, which demonstrate the benefit of coming down to approximately 7.5 French. The smaller scopes are the way forward, but should we have an optimum size, because the working channel is important? Should we keep these special scopes for more complex patients with comorbidity, use suction scopes for patients with matrix, large volume stones, and use additional suction steerable access sheets if the large volume burden requires the fragments to be removed? Could we also identify the patients with narrow, tight ureters And one could also argue that should we be using reusable scopes in patients who are run-of-the-mill 8 millimeter stones in the renal pelvis, for example. But if you are in part of a group practice, you always have to check the fiber optics, especially when you're used to the really good optics of a video single-use flexible ureteroscope. Then to go back to using reusable fiber optic or video scopes, especially in diagnostic ureteroscopies or tumor management, is quite challenging because you're used to real good quality. And the other benefit is in patients who one needs to be radiology free and or stent free. Thank you.